We are very fortunate today to have Stephanie Wheeler, PhD, MPH, and Don Rosenstein, MD, joining us for If You Have to Ask, You Can't Afford It, Addressing Financial Toxicity Among North Carolina Cancer Patients. Dr. Wheeler is a health services researcher and decision scientist focused on quantifying the social, behavioral, and clinical and organizational factors that affect healthcare access, quality, and equity. Her research portfolio is primarily focused on cancer care delivery, with particular emphasis on improving value, understanding the financial and psychosocial impacts of cancer, and reducing health disparities. Dr. Wheeler, welcome.
Thank you for having me.
Thank you. And what's one thing that's not on that bio that we should know about you?
Well, let's see, probably the thing that's top of mind is I have 4 small children under the age of 7 at home, 2 of which are twin 18-month-olds. So when I'm not working, they are capitalizing on all of my time.
I'll bet they are. Well, we appreciate your finding time with everything else going on to be here and to present this lecture. Thank you so much.
Sure.
Dr. Rosenstein is director of the UNC Comprehensive Cancer Support Program with joint appointments in the departments of psychiatry and medicine. He also serves as division head of general adult psychiatry. The Comprehensive Cancer Support Program, or CCSP, provides UNC oncology patients with a wide range of educational, medical, psychiatric, and psychosocial services. The clinical, teaching, and research aspects of this program operate at the North Carolina Cancer Hospital and Carolina Point 2. Dr. Rosenstein, welcome.
Thanks very much, Tim. I appreciate it.
Thank you. And as I'd asked Dr. Wheeler, what's one thing we should know about you that wasn't on that bio there?
That since the pandemic, I've become a dedicated walker and a listener to podcasts. And so when this lecture is over, despite how cold it is, I'm going to put on my earbuds and listen to Barack Obama's memoir as I go for a walk.
Oh, good for you. Good for you. That sounds like a worthy undertaking. All
Great
right.
book.
We mentioned that we're going to be using Poll Everywhere, and these are all anonymous. The first question, we usually try to give you kind of a softball on this first one. Financial toxicity describes problems a cancer patient has related to the cost of treatment. So if you think that's true, A, false, B, and that'll pop up in your Poll Everywhere in just a minute. And we'll come back to that, but this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William Wood, MD, MPH, and CPD staff have no relevant financial relationships with commercial relations as interests as defined by the ACCME. Stephanie B. Wheeler, PhD, MPH, and Donald Rosenstein, MD, have no financial relationships with commercial interests as defined by the ACCME. And there's our poll. And if you just to Dr. Rosenstein and Dr. Wheeler, to let you know, things a little bit off with my view, so I'm not able to see your video. I know everybody else is, so I won't be able to pick up on visual cues, just so that you know that. How are they doing? Looks like we are running about 92% true, 8% false. How are they doing?
They're doing very well. So the types of problems that cancer patients face related to the cost of treatment is certainly in the realm of financial toxicity, and we're going to talk more about what that looks like in just a few minutes.
Great. All right. Thanks so much to everyone for jumping right in with Poll Everywhere there. Advance the slide. Addressing cancer-related financial toxicity in oncology care settings.
Okay. And I am happy to take over now. Tim, if you're ready.
We are. And our first slide is this is a word cloud, our first Poll Everywhere question after the icebreaker. So what we'd like you to do here is put in one word that you associate with financial toxicity and cancer care. So bankruptcy, there we go. We've got our first one, and I'm guessing we might have some repeats on that one. Depression, stress. So again, totally anonymous. put in one single word that you associate with cancer and financial toxicity. We'll take about 15, 20 seconds to let more people enter these. This is really great. We appreciate all the participation on this.
Tim, you didn't tell us that you were going to give our talk for us with this very first icebreaker. There you have it. It's all right there, and
it's done. Yeah, yeah. Were it not for that 50-minute requirement, we'd be all set. Just kidding. I know you've got a lot more to teach us. All right. So, tell me your impressions of the word cloud here.
I mean, this is right on target. I think these are all common concerns that patients and their caregivers face when dealing with financial toxicity. So right on target.
Right.
And kudos to those people who mention mortality. It's kind of a spoiler alert, but Stephanie will talk more about that. But that's kind of a interesting thing that many people wouldn't normally associate with financial toxicity.
Mm-hmm.
Yeah.
I also think that some of the words in here that reflect anger and also unnecessary are worth noting because I think that is a common reaction that many patients and their caregivers aren't expecting the costs to be so catastrophic, and that there's a increasing awareness of just how limited our safety nets are, including health insurance, right? Even well-insured people are struggling to afford the cost of their care. So unnecessary concern about this and anger over this, I don't think is an uncommon emotion.
Right. Well, thank you. We'll go ahead and move on to the next slide here. And how do you want me to add all of the, do you want me to take these one at a time, Dr. Wheeler? Okay.
No, just go ahead and click on through them. This is an animated slide, and I'll talk through it. So I think that unless you've been living under a rock, which I know during COVID, sometimes we all feel like we're living under a rock, you're probably familiar with the overarching concern nationally about the cost of healthcare, and particularly the cost of cancer care. This is an ongoing issue, in particular as it relates to drug costs, and it's something that's made its way into the national media in a large way. And we've seen 60 Minutes episodes about this, and as you can see here, a lot of articles in Washington Post, New York Times, and other important news sources. We can keep going, Tim. So I think that it's important to recognize that we are unique compared to our developed country counterparts in the increase and the percentage of our overall healthcare economy, or overall economy in terms of the percentage we spend on healthcare compared to all of these other countries. So you can see here the percent of U.S. Spending on healthcare as a percentage of our GDP far outweighs our other counterparts. And our healthcare spending has, almost exponentially increased over time. And particularly, I just want to note, where our GDP production is, which is here in the dark gray bar, and then our wage increase in the light gray bar is really quite insignificant compared to the cost of healthcare nationally. So this is a grave situation. I think most of you, because you're working in healthcare, probably realize this, but it's something that we desperately need policy attention to. We can keep going, Tim. So the thing that this talk is focused on is obviously cancer care, but I just want to note that the cost of drugs in particular is a very big concern. We're spending more for the exact same medications as our global counterparts are. And this is just a sampling of several drugs that are currently available to treat a variety of healthcare conditions. You'll see several on here that are specific to cancer, including Avastin and Herceptin. But we spend vastly more than our counterparts in England, Norway, and Canada on these exact same medications. So this really isn't a question of the quality of care or the even quantity of care, when for the exact same quality product or for the exact same quantity product, we're actually paying much, much more. Next slide, please. So how does this translate for individual patients? Well, aside from the policy issues that we're facing as a country, This clearly translates to real concerns on individual patient levels. So as many as 30% of cancer patients experience financial toxicity, which again reflects the significant financial harm to patients associated with the cost of their cancer care. And this is significant not only because it directly affects patients' bottom line in terms of their out-of-pocket expenses and their ability to pay for other types of needs that they may have as a household, but it also translates to real health outcomes that we care about. So lower quality of life, psychological distress, delayed treatment, and then we've even seen evidence that patients with significant financial distress experience higher mortality. So this extends beyond, again, the sort of economic experience. And I'll also note that the bankruptcy is not an uncommon outcome. We also know that for patients going through cancer treatment, dealing with the cost of their care, the use of GoFundMe accounts and other types of crowdsourced financial support is one of the #1 strategies that patients and their families take, and it's the #1 reason why people start those kinds of accounts in the first place. Next slide, please. So in the work that we have done, we initially started looking at this issue in metastatic cancer, and I'll talk just a little bit about that research, and then I'm going to broaden out, kind of zoom out to talk about other work we've done based on what we initially learned in the metastatic context. So we started working in metastatic cancer in particular because there was little known about financial toxicity in this particular population, despite lots of other literature showing that this is a growing concern for cancer patients at earlier stages. And we thought that this was potentially an interesting group to look at because we know that they have a complex and changing treatment regimen given the progressive nature of their disease. We know that the psychosocial impact of living with advanced disease is also significant, especially when prognosis is not good, and that patients are, again, living with terminal illness. We also know that more medically underserved populations are likely to be diagnosed at advanced stages. So this would include the uninsured, patients of color, and sometimes rural patients in communities where resources are not adequate to provide their care. And so we thought for these reasons that metastatic cancer patients in particular may face increased risk for financial toxicity. Next slide, please. So as we started to look at this issue, we partnered with the Metastatic Breast Cancer Network to conduct a survey to understand these issues in more depth. And so we looked at baseline financial vulnerability. We looked at the material burden in terms of the out-of-pocket costs that patients were facing. And we also looked at the psychosocial distress as well as behavioral responses, including coping strategies like changing medical spending or delaying treatment, as well as changes to non-medical spending, like changes to vacation planning or changes to other types of expenses at the household level, as well as changes in employment. Next slide, please. So in doing this work, we learned a couple of things. First, we recruited over 1,000 individuals from 41 states. 30% of the people completing this survey were uninsured. Next slide, please. We also found in this group that uninsured participants were more likely to identify as racial or ethnic minorities. Next slide, please. And the uninsured participants were reporting lower income, but were much more likely to be working in full-time jobs. So I think that's an important point about the uninsured group of people who are living with metastatic illness in this population. Next slide, please. By the way, this was an online survey that went out to the Metastatic Breast Cancer Network membership. Should have said that a minute ago. So in terms of overall financial security, I think some of the outcomes you can see here are rather striking, that almost 50% of people in the sample had been contacted by collections. Over 50% had stopped or refused treatment due to cost. Many people reported that they were not able to meet their monthly expenses, that they were not financially satisfied or in control of their situation. And over half reported they didn't have enough in savings to cover the cost of their care. Next slide, please. We looked at these data by insurance because we suspected that insurance was protective against many of these outcomes. And so that is, I think, reflected somewhat here, where you see uninsured patients being much more likely to be contacted by collections, stopping or refusing treatment, with some variability in terms of not being able to meet monthly expenses and not being satisfied with their situation. Next slide, please. But we also looked at not just the out-of-pocket material burden, but the level of psychosocial distress associated with the cost of care. And here, I think, again, you see rather striking findings in terms of the overall distress that was reported by the sample. So almost 70% of people were worried about financial problems as a result of their cancer. Almost 50% reported their out-of-pocket expenses were more than they expected, that they were financially distressed. 40% were saying that they were unable to work and contribute to their household economic situation fully. And about a third were distressed about not knowing what the cost would be. So the uncertainty, as well as worry about financial stress on their families. And the next slide, please. We can look at this by insurance status again to see to what extent was insurance protective. And I think what was striking and interesting here, and we didn't expect to see, was that our insured respondents reported higher levels of psychosocial distress than our uninsured respondents in terms of all of these outcomes, and these were statistically significant. Next slide, please. So I think one of the important takeaways from these findings is that the out-of-pocket material burden versus the stress level and the worry about that out-of-pocket burden are potentially experienced differentially by people who are uninsured versus those who are not. And so here you see adjusted findings in terms of the relative risk for these outcomes by insurance, where folks who were uninsured were much more likely to report that they didn't have enough money to meet their monthly expenses, or that they stopped or refused treatment because of cost, whereas our insured participants were more likely to report that they were worried or financially stressed about their cancer care. Next slide. And these are fully adjusted models again, so controlling for things like age, race, time since diagnosis, and so forth. So I think one of the takeaways from this study was that, first of all, there was an unprecedented level of financial harm in this population of metastatic breast cancer patients, more prevalent than what we had seen in other early stage breast cancer patients, as well as early stage patients more generally. The other thing that I think was really important, and I alluded to this, is that the different dimensions of financial toxicity potentially are relevant to patients in different ways, and that insurance can be a mediator of those kinds of financial toxicity outcomes. So again, our insured patients were more worried about the cost of their care. Our uninsured participants were less able to afford the cost of their care and had more out-of-pocket material level burden. And so what we think that this tells us is that this is a multidimensional concept. It's important not just to measure worry. It's important not just to measure the total dollar amount that patients are faced with. It's important to measure all of these things, because if we only identify those who are most worried or distressed about the cost of their care, we may actually miss those who have the highest material need in terms of the out-of-pocket expense at the household level. Next slide, please. So as we begin to learn from this experience, and we're going to take a little poll right now, it inspired us to do a few more things in our research group. But let's stop and ask, which one of the following is not one of the three main components of financial toxicity? And we want you to use Poll Everywhere to answer this. So choice A is the material out-of-pocket cost burden, choice B is behavioral coping strategies, choice C is distress, and choice D is physical functioning.
All right, and just a reminder, totally anonymous, so take a chance on this. We have a really sharp audience always, so I appreciate everyone's participation. Maybe take another 5 seconds if you haven't had a chance to answer this yet. Right, Dr. Wheeler, what do you think?
All right, it looks like 96% of people are answering correctly that physical functioning is not one of the three main components, and the other three are of our definition of financial toxicity. So that looks great. Thank you guys for responding. And we can keep going. So one of the next things we did was work with our State's Oncology Navigation Association and conduct another survey of oncology navigators to better understand the types of financial support that institutions across our state and a few others offered. And we were encouraged to see that many oncology navigators reported a wide variety of resources that were available, including charity care, assistance applying for insurance, assistance with medications and financial counseling, as well as payment plans and assistance with housing and transportation. But next slide. Unfortunately, one of the things that came out of this survey was that even when patients have concerns, there may not be a way to always address them. In some cases, patients were a bit worried about how the quality of their care might vary if their providers knew about their costs. And then also, I think some of the oncology providers felt like that they didn't always have time to discuss this. But I will say this is a minority of responses. For the most part, these were not concerns among this oncology navigator group. And it was also not a concern of this group that it might have been inappropriate to discuss the cost of care. Most of these people felt like that was important and was part of the high quality care that they provided. Next slide. So as we think about the types of services available, we went on to evaluate those at our own cancer hospital. And we did a variety of interviews with folks at the UNC Cancer Hospital, including many of the staff that work with our oncology patients, and many of the administrators and support staff that surround the cancer hospital. And we learned a lot about what services were available here at UNC. Interestingly, we learned a lot about the gaps as well in terms of what services we offered. So listed here on the left are a whole bunch of resources that are currently available through the UNC system. And then what you see is the stratification by which of those resources target uninsured patients versus underinsured patients. And as you can see, many of our underinsured patients, so these are people who have healthcare insurance, but who are not eligible for many of these services, this is where many of the gaps were. And not only in terms of the systemic identification of that need, but also the ability to navigate people to those resources, this was significantly lacking. I will say also for our uninsured patients that there was, in many cases, processes lacking to get them through these support and referral networks as well. Next slide, please. And so this series of interviews that we did with a lot of different people in our system contributed to a process map that we developed for the UNC healthcare system for our cancer patients. And if you're not familiar with a process map, this is a visual representation of a specific process, and it is intended to create shared vision and a shared language and to identify places where we can improve workflow. And so one of the goals is to look for gaps in this process and to reflect a shared understanding of how things work. Next slide, please. And so as we mapped out the UNC healthcare system's process, you can see that it was a hot mess. I don't know how else to describe it other than saying, again, we were very encouraged by the number of resources available, but as a patient, trying to get through this system would have been extremely challenging. Even for our most educated, activated, literate patients, finding your way to the appropriate resources would have been difficult, particularly in the context of a cancer diagnosis. And so you can see here a couple of things I just want to note. That the color of the arrows reflects the referral process and whether it was patient activated or provider activated. And what you'll see is that there are a lot of patient-activated referral processes here, which basically means that if a patient has a concern, they're given maybe a piece of paper that says, you should go talk to the Medicaid case manager, and they can help you with getting onto Medicaid if you're eligible. But that process really relies on the patient having to champion for themselves and activate that process to make sure that it happens, as opposed to a provider or a staff referral process where maybe there's an order entered in Epic and there's a way to directly get those patients into care proactively through referral to a social worker, for example, who then calls the patient and helps them with the eligibility, helps them with the applications to get access to these programs. And so what we realized in looking at this is that we would like to see more staff and provider activated processes and less reliance on individual patients to do this, because I think that's where people fall through the cracks. And indeed, that's something that we found in our patient interviews as well. So the takeaway from this is that we have to do a better job with getting patients through this system. And there's fortunately an evidence base for how to do that. Next slide, please. So thinking about kind of the summary of some of this literature to date, and we've been working on this issue for about 5 or 6 years, and there's other studies, I think, that our group has done that contribute to this science. We know that there's a heavier burden of financial toxicity in metastatic patients as well as medically underserved patients, including patients of color and rural patients in our state and in other states. There's a lack of systemic and ongoing identification of need in our systems. We know that financial distress may not reflect the material out-of-pocket burden that people face. There's a lack of coordinated, streamlined applications, and in many cases, redundancy in the applications that patients are completing. There's a lack of resources for the underinsured patients in our state and in others, and really we don't have a clear navigation process in place to assist patients and their families. Next slide, please. So going forward, we were interested in thinking about potential solutions. And fortunately, as I said, there's an emerging evidence base around the power of financial navigation. And financial navigation is a type of intervention through which patients undergo proactive screening with a navigator, and a needs assessment is conducted. And at that point of needs assessment, there's an eligibility determination for a variety of different programs, whatever may be available locally, as well as programs that may be in existence nationally or regionally. And so this assessment includes not only that eligibility, for example, for programs like Medicaid or for Social Security disability, but also there's an assessment of what kinds of difficulty patients are facing with the cost of their care. And this would also require an assessment of the income and the wealth at the household level, as well as concerns at the household level about non-medical spending. All of this information taken together in a standardized way can help direct a trained financial navigator to guide patients through a process through which they can access financial support resources. And so this usually takes a couple of appointments past the initial intake, whereby financial navigators, again, specially trained to do financial navigation, so not folks who have been co-opted for this role, given all the other things that they're doing, but people who really understand all of these systems in depth. Those folks can assist with applications, with eligibility requirements, with understanding what's needed in terms of paperwork that needs to be submitted, and then can follow up and ensure that those actions are being taken, and where relevant, potentially appeal any denials that can come along the way. So I think this is a really interesting potential solution. Many of you may have financial navigators at your own clinics or care centers, and if you don't, it's something that we'd be happy to provide some additional insight and evidence about. The initial model of this was actually tested in the Washington State area with some colleagues out there at the Fred Hutch Cancer Center, and we've adapted it for use here in North Carolina. And I'm going to turn it over now to my colleague, Don, to take over from this point. Don?
So much, Stephanie. Can you all hear me okay?
Yep.
Good. So what Stephanie just laid out so clearly is that this is a large, very complicated, and growing problem. I don't think we've even begun in this country to start to contend with what we're going to see as a result of the pandemic and some of the changes. So one of the things that Stephanie was just mentioning that we landed on is what can we do to make things better? And so what I'd like to do in the next few minutes is take you through some of the studies using financial navigation and how we've done that to just outline kind of where we're going and how we kind of like to address the problem. So Tim, if I could have the next slide, please. And one of the things I want to point out is that, you know, we shared with you kind of our complicated and not particularly pretty process map. And as I'll mention in a few minutes, we've been engaged with several different cancer centers across North Carolina doing a similar kind of work. And what is so clear about this is that if you've seen one cancer center, you've seen one cancer center. These are all kind of individually distinct and have their own processes. And so one of the interesting things that we're struggling with is kind of what should financial navigation look like? What are the core components of it, and how can we best implement that in different settings that make sense for individual needs? And as Stephanie kind of describes so nicely, you can't, it's not one construct of financial toxicity. There are so many different components of it that affect people in different ways. And what obviously we're all interested in is meaningful financial and clinical outcomes by doing this work better. We're under no illusion that financial navigation is going to solve the problems of our healthcare system. And certainly there are lots of efforts being made to expand Medicaid and to provide all sorts of relief for the high costs of medications that are going on. There are lots of policy, political, institutional efforts to try to make this happen. But in the meantime, there are real people every day who are trying to navigate this in the midst of having cancer and being really sick. And I'm always struck by how there are some people who show up in clinic on their own, very overwhelmed with limited kind of medical literacy. And then there are other people who come in with a team of folks who have 3-ring binders who are taking notes and collecting all the cards and act as a lend-lease prefrontal cortex to help people kind of navigate all this. So there's a lot to this. The next slide, please. So one of the first things that we did was we used funding from the UNC Center for Health Innovation to do a pilot study where we wanted to see if we can put in place a financial navigation program with the following 2 goals: to come up with a clear distress screening strategy. And again, there are so many different ways to screen for financial distress. And one of the grants that Stephanie and I are on had a kickoff meeting yesterday with about 10 different groups, 9 of which seem to be focused on how best to screen for financial distress. And there are lots of different ways to do it, lots of different tools to do that. And we wanted to develop what our screening process would be at the North Carolina Cancer Hospital. And then what we wanted to do is to design, implement, and evaluate a pilot project for 50 patients with cancer who screened positive in our in that first goal for financial distress. And I keep punching the arrow on my computer, but Tim, you have to advance the slide for me. Next one, please. So this was a very simple design. It was a pre-post intervention design that started in January of last year. Seems like a lifetime ago. We did not limit it to any particular cancer type. Patients were referred through a number of different mechanisms through the care teams and social workers. And the tool that we used to determine whether people met eligibility criteria for this pilot was a score on an instrument called the COST, Comprehensive Score for Financial Toxicity. It's a validated instrument. The tricky part about it is that it's scored kind of in the opposite direction that you would expect, so that a high score on the COST represents less financial toxicity, and a low score represents high financial toxicity. When we initially designed this study, we were going to have kind of 2 arms of it, kind of treatment as usual versus the financial navigation program. But all 50 of the first 50 patients who were referred to our program screened positive for financial toxicity and were enrolled. And so this was a 1-year grant, and then we collected a number of different outcome measures that I'll show you in just a minute. Next slide, Tim. So this is what the design looked like. High financial distress is indicated by a low score on the, God, if I mix that up, Stephanie, oh my goodness, I haven't. The higher the score, the lower the toxicity. So we wanted patients who had a score of lower than 22, correct? 22 or lower to get into the study. Right. And then if you did get into the intervention, then there was a very detailed financial intake assessment. And there's no kind of rocket science behind this. What we were very fortunate in having is 2 enormously talented people who do this work, Cindy Rogers and Julia Rodriguez, who do a lot of this kind of assessment. And this was basically us spending a lot of time with them, asking them, what are the most important questions that you think we should be asking patients, and then codifying this and putting it into a formal assessment. And then there were kind of, as Stephanie described earlier, every 2 weeks as needed meetings with the financial navigators. And then there are referral processes for more complicated needs, and then a variety of post-intervention assessments. But as I just mentioned, we didn't have anyone in the standard of care, usual care arm in this particular pilot. Next slide, Tim. So the kind of core components of this are this initial assessment, which is really quite detailed. And it's important to mention that these are very personal questions that you're asking people. This gets right at the heart of where they live, kind of what their circumstances are and what their income is and what their liabilities are and kind of what they're eligible for. And so this is not a trivial matter to kind of do a very careful assessment of people's needs and vulnerability. And then there was this kind of consultation initially, triage services, and then these multiple follow-up appointments. Next slide. Here, just a slide of describing the population that we had. The mean age was about 50 years, slightly more than half of subjects were female. We had, I think, a nice mix representing our the community that we care for at North Carolina Cancer Hospital. And as you can see, kind of a nice mix with respect to being insured or uninsured or underinsured, which is a concept that I've learned working with Stephanie over the years, which is more and more relevant. Next slide. And even though this was not kind of a randomized controlled trial, this was a pre-post design, what you can see is that for all comers, there was a very significant improvement, so an increase in the cost scores, improvement in kind of level financial toxicity, and we found that in both the insured and uninsured groups. And this basically provided us with the pilot data for a subsequent study that I want to tell you about next. Next slide. What you can see here is that is another level of detail of the pilot study. There are multiple components to financial toxicity, as we've been talking about. And if you just look at these first two, kind of this was getting right at the level of distress and worry, which were like quite different pre and post the intervention. And on the next slide. We were also interested in implementation outcomes as well in the study, because we had had ambitions from the beginning, if this was successful, to try to roll this out at a larger scale. And so what was nice is that we've got, great completion of our forms, almost all finished an application for financial assistance and received some level of financial assistance. And you can see a breakdown of the types of assistance that people received in the bar graph below. One of the things that I'm not sure that we mentioned yet is that when we were first doing the initial exploratory work, one of the most remarkable findings that we had was that fully 2/3 of patients who started an application for charity care did not complete it, which may not be surprising to those of you who are on the front lines and working with folks. There's just a lot of paperwork and a lot of time that you need to spend applying for various things. And so this was one of the most important things that we wanted to follow in this pilot study of navigation, is kind of the follow through and people really finishing up their applications and seeing what happens when you get through the whole process. Next slide. Here is the bar graph just demonstrating the ways in which participants agreed with statements about their satisfaction with the intervention. And you can see from the quotations of the questions that we asked that we really were interested in several different aspects of this, and level of comfort in talking with the financial navigator. This was all related to kind of the feasibility of doing this on a larger scale. And this went quite well. And we have pages and pages of quotations from people describing how meaningful it was for them to kind of have someone be at their elbow essentially and walk them through this and feel like they're not in this on their own. Next slide. So this led us to the next step, which is an R01 grant that is currently underway. We're in our second year of this. And this was in response to a call from the National Cancer Institute to address a number of different problems with cancer care delivery in rural areas. And so Stephanie and I wrote an application to extend this financial navigation program to rural cancer centers throughout North Carolina. And I won't read these specific aims to you. You can see them for yourself. But they essentially mean we wanted to understand what the practices were as best we could in the same way that we understood our own practice site in Chapel Hill. We wanted to kind of learn about the implementation determinants and implementation outcomes, basically kind of what works and what doesn't when you're trying to put this in place, and then enroll several hundred patients and evaluate the effectiveness of financial navigation in improving various outcomes. Next slide. And I hope that of the 192 participants on this call, there are several from one of our various sites, because one of the cool things about this grant is that initially there are very strict guidelines from the federal government about what constitutes a rural site and what doesn't. And so initially these were the 5 sites on the left that met the kind of federal definitions of rurality. But we were interested in other sites as well. And then through a supplemental grant that we were able to obtain kind of on top of our kind of core cancer center grant at UNC, we were able to add 4 sites that are non-rural, defined as non-rural as well. So we'll be able to kind of compare and contrast different settings in the implementation of this financial navigation intervention. Next slide. You can't give a talk in North Carolina without having a map of North Carolina. We've had a chance to travel all over the state, meeting people and kind of preparing for this work. And what you can see amongst the different counties represented here in blue are counties that we've had various relationships with over the years. And so we set up, through a different study several years ago, a network of individuals who are interested in providing cancer survivorship care throughout North Carolina. Those are in the blue. And in the pluses and in the asterisks are the 9 sites that I just mentioned on the slide before, the rural and non-rural sites that are participating in the R01. Next slide. I'm not going to walk you through this because it's small print. This is basically our study schema for the R01, which essentially, again, in the main areas describes what the setting is like, and that's what we did in the first year. And then we are assessing both how well this navigation program is implemented and what the outcomes are. But the first phase of that second half of the study is in training financial navigators who have been either hired or kind of dedicated time at each of those 9 sites to doing financial navigation. And so we're in the process of wrapping up our training process, for financial navigators now, and then starting in February of 2021, we will be enrolling as many as 700 patients throughout North Carolina. Next slide. So what we did in the first year is we drove all over the state. We met a lot of people. We got a sense of what the level of interest was and kind of what the various complexities of different cancer centers are. We wrote our kind of protocol to submit to the IRB. We then recruited stakeholders in each of the sites so that we can really understand what the local setting is. And then we did process mapping, just like Stephanie showed you a few minutes ago. And we also wanted to get a sense of how ready for implementing change the various organizations were. We then met with each of these sites and we said, did we get it right? We went over the process map and kind of fine-tuned it. Did we hear you correctly? And this is how things work where you're at. And then we also put together really an extraordinary external advisory board to kind of help guide the research going forward. I've already mentioned that we submitted that supplement that allowed us to add the non-rural sites, and then we're off and running. Next slide. Let's skip over this. It's unreadable. Let's go to the very next one. So as part of the training process, you know, the centerpiece of the training approach is a pretty extensive financial boot camp that's provided online by the Association of Community Cancer Centers. If you're a member of the ACCC, you can kind of sign up for this. It's really quite thorough. It's an online process. And so the financial navigators in this grant are doing that at the same time that we're walking them through internet-based Zoom calls, essentially describing the study and how we're going to do it, kind of how you screen for financial toxicity, and kind of how to use various components of a database that we have for this. We can talk about that in the questions and answers if we have time, if people are interested, but let's move on to the next slide. The financial navigation program itself involves just what you've heard so far. You have to identify people who have high distress. There's this initial assessment to walk them through. It's hands-on assistance with applications. Really importantly, it involves tracking and monitoring the various outcomes through an electronic database. This is perhaps one of the most important lessons we learned from the pilot, is that making this standardized, organized, having clear ways to follow through with the database makes a huge difference, because as you might imagine, when you're doing this with dozens of patients, it's really easy to lose track of where you're at. And so having kind of an organized approach that can help you track where people are at makes a huge difference. Next slide. And so this is just a modification of the schema that I showed you earlier, and this is what we're doing at the 9 sites throughout North Carolina. The one important point I want to make here is that for those patients who have particularly complicated needs, or when the financial navigators locally kind of have exhausted what they've been able to find, we've partnered with the Patient Advocate Foundation, and they have case managers, case workers who kind of have who are specifically trained to kind of understand various resources, national resources that can help as well. And so because this is a study, we're actually going to be not only administering the program, but then evaluating it very carefully in all sorts of ways so that we can understand some of the differences between rural and non-rural sites, and kind of how individuals kind of respond to this, and kind of what works and what doesn't, so that we might even be able to take it even to a larger area going forward. Next slide. These are some of the tools that we will be measuring that I don't need to kind of belabor right now. The important thing, again, is that we've got this REDCap database that allows for really detailed notes and checklists about patient encounters, and is going to facilitate the navigators' help with patients. We're going to be recruiting 100 people roughly in each site going forward, and so it's a lot of information to keep track of. And on the next slide, I believe, if I'm remembering correct, we've got some of the other measures and tools that we're going to use. The cost instrument that I'll show you in just a moment is what we use to screen, determine a level of financial toxicity, and it's also kind of a critical outcome to see whether we can improve level of financial distress in folks. And then there are all sorts of other perspectives and experiences, both from the financial navigators, that we want to look at. So here's the cost instrument. It's 11 items. Was published by Jonah Souza back in 2014. And we've added several other questions about financial distress to this, but that's the main measure, and it's easily found online if people want to use this. Next slide. This is the database that we're using. I'm happy to answer some questions about it if folks have some questions, but let's keep moving so that we can wrap up and take some questions. One of the outcomes that we designed as part of our initial pilot area is kind of some handouts and website resources for patients to kind of help keep track of where they can go for various financial assistance. And on the next slide.
All right, and here we've got
done.
our last question for you. Yeah, how can financial navigators help patients experiencing financial hardship? And so A, understanding and reviewing healthcare bills for accuracy. B, completing Medicaid and disability paperwork. C, applying for medical and non-medical cost assistance programs. D, identifying resources for psychosocial support. E, addressing caregivers' financial concerns, or F, all of the above. And if you take just 6 or 7 more seconds and go ahead and make a choice on that. And then be thinking about what questions you have for Dr. Wheeler and Dr. Rosenstein, because you'll be able to start submitting those in just a minute here. All right, Dr. Rosenstein, how did they do?
They did exactly right. Smart group.
Absolutely, always.
I just noticed in the chat someone's comment about a single payer. Stephanie, you want to respond to that? I've been in favor of a single payer for a very long time, but I'm also a realist.
Yeah, I think it's a really interesting point, and obviously one that folks like us are discussing, but also has been discussed on a national stage. I do think that it probably would relieve much of the concern, certainly that uninsured patients face, but also the existing fragmentation in our healthcare system and people falling through the cracks. Clearly, part of that I think could be administratively avoided if we just had people that are linked to care through insurance. Of course, policy is difficult, especially that kind of policy. And so we'll see what happens. I mean, in the next few years, I think this is going to continue to be a national discussion. In the meantime, as Don said, financial navigation is not a silver bullet. It's not going to fix all the problems, but we see it as a start in the right direction to at least alleviate some of the difficulties patients are facing now in the absence of a larger health insurance expansion effort.
So Tim, well, if there's a question that you're going to ask, let me just first mention, let's go back one slide. I just want to make sure people kind of appreciate what a great team we have and how many people are involved in this. And in particular, I want to call out Michelle Manning, who's the project manager on this, as well as this remarkable advisory board that we've met with now, and they've given us some really great feedback. But we've got, this takes a lot of people to put this together, and want to make sure that they're acknowledged. Tim, are there questions that have come to you?
There sure are. So here's our first one, and just a reminder that this is open to anyone who'd like to ask questions. So go ahead, Poll Everywhere should be open for questions now. Our first one, can you advise if financial navigation services are a billable service for insurance / Medicare to pay?
Wouldn't that be something?
Yeah.
I mean, right, at this point, no, there's not a billing code that we're aware of for financial navigators specifically. I mean, some of the services that they provide are through the sort of auspices of social work, but there's not a dedicated billing code that I'm aware of at this point. Don?
But I would say that what we have some preliminary evidence for this, and what the hope is that if you do this right, this, you get more than your return on investment back in terms of kind of better outcomes for patients and patients receiving resources that they're eligible for, and hospitals and cancer centers getting paid for the work that they're doing as well. So we think that this is well worth the investment of money for someone who has this as a dedicated part of their work.
All right. Thank you so much.
I was just going to quickly add, that's one of the things we hope to quantify better in this current implementation.
Gotcha. Next question. Have you already seen how COVID is affecting already vulnerable and marginalized patients financially and in turn emotionally, mentally?
Don, you want to take that one?
Yeah, I mean, it's mostly anecdotal at this point. We hear so many stories, and you know, it would be shocking to us if, when the dust settles and we have really good hard measures of how many people lost their jobs and as a result lost their insurance and as a result had their cancer care compromised, if that just wasn't kind of a huge wave that's just more delayed than the wave of positive COVID tests. But I'm not aware, Stephanie, I don't know if you are, of kind of reports of yet of exactly what the impact is.
Yeah, I don't know that we have that evidence yet, but I know several studies are underway.
All right, thank you. Next question. How do financial navigators stay up to date on community, national, nonprofit, charity opportunities? Great question.
This is a terrific question. That's one of the reasons why Don shared the resource guide there at the end that we're working to create. We're going to have a website. We're working on a website for our study now that will be one place where we hope to include some of that information. There's other websites as well that we could assemble and send out to the group if that's helpful, that catalog some of these resources. The person asking the question is correct that these change rapidly, and certainly in the context of COVID, particularly nonprofit organizations are facing shortfalls in their donations right now, and that clearly has an implication for the amount of resources available to patients. So I would say it's an ongoing task, and one that is challenging and is even more of a motivation for us to try to create inventories like that to provide to people so that people don't feel like they're on their own trying to look for this information.
All right, thank you. Next question. What is the most important policy change that you feel is necessary to reduce the financial burden on the oncology patients?
Such a great question.
Mm-hmm.
in our state,
Yeah.
I would say Medicaid expansion is the most significant policy change that we need in North Carolina right now. Not only to cover people who are under the current Medicaid income eligibility criteria, but also to expand it to a broader group of people who don't meet the very limited definitions of groups right now who are eligible, and to try to capture more of the folks who are near poor, who would benefit from the generosity of Medicaid services for patients.
I agree completely.
All right.
Right to your representatives.
Yeah.
And would like a patient to get estimated cost plan based on different treatment plans and potential outcomes as well. This may be a continuation of the one above it. As someone who works with one of the teams at UNC that provides financial assistance to our patients, what do you see as a future where we can all work on the same team with assisting patients?
Yeah, I can tackle maybe the first part, and Don, if you want to tackle the second one as a member of the healthcare system. So cost transparency is part of this and is really important and relevant. It's made difficult by the fact that we have a multi-payer system and different negotiated rates, particularly for private insurance plans. For that reason, it can be really difficult to get an isolated, point estimate for exactly what to expect. And then, of course, treatment plans are evolving as well. And so it's often not clear at the initial point of contact with a patient how the treatment is going to change going forward. That said, I think we still need to tackle this. There's a number of efforts nationally and regionally that have attempted to start presenting cost information, at least, ranges of cost information. We've been told that there's a similar effort in the UNC system that I think is only currently viewable to providers, or may only in the future be viewable to providers. But I think we need to start looking at how to present that kind of information to patients to at least give them some ballpark estimate for what to expect. And there are ways to do that. The science at this point is underdeveloped, and so there's work to do.
Yeah. With respect to the second part of that, or the second question, yeah, I think modern cancer care is fragmented, especially at academic medical centers, and a lot of us feel like there's a lot of room for improvement to have more cohesive, team-based approaches. What we can tell you is that in traveling around the state and seeing a lot of other places, especially smaller community cancer centers, I don't think that's as much of a problem. And you know, very often there's just kind of one or two people involved in doing this, maybe a social worker or a financial counselor, and many people do feel part of a team. But I think that this is about culture change. It wasn't that long ago that it was really considered poor practice to bring questions about money into clinical encounters. And I think that, you know, over time, more and more oncologists see this as an important part of their job, and will have these conversations with their patients, and will and are expressing interest in knowing who the content experts are with respect to this within their own centers. So I do kind of look forward to that time where it's kind of less fragmented in cancer centers. It's a good question.
Gotcha. We're going to take two more questions, and I apologize to our audience because we have so many good questions coming in, and we need to wrap up here in just a minute. So any data that is linked to with your financial toxicity intervention and survival and quality of life? Another great question.
Yes, we do have data. Well, partly yes. We have data on quality of life improvements from our pilot study, and we are collecting detailed quality of life information in our current study, the R01 that's being done in the 9 sites across the state. So we will have good information about how quality of life is changing over time. Survival data, we don't have any of that yet from our studies, and I don't know that we would expect to see a lot of differentiation in survival in the time frame that we're looking at. You know, the studies that have been done thus far, linking financial distress, it's the most extreme forms of financial distress, including bankruptcy, to higher cancer mortality and all-cause mortality, have been done in really large secondary databases, linked data sets. And you kind of need those numbers to be able to see that outcome, and you need them over a long period of time to be able to really capture some of that data. And I just don't know that in the time frame of our study that we would see that outcome.
What we do hope to see, though, is perhaps some intermediary measures looking at behavioral responses to financial toxicity, and kind of learning more about people's decisions about you know, when they're faced with, you know, filling their prescriptions or so on. So I think that there's a lot of room in between the financial toxicity and mortality data, understanding how that actually plays out, and we're hoping to get some pilot data about that.
Yeah, that's a good point. Just to quickly add, I didn't say, but I think Don alluded to this, like the mechanism of how financial toxicity affects survival is probably at least one way through the treatment process itself. And when patients are delaying or stopping their treatment, then there's going to be a little bit of a lag from when you see that, in theory, start to affect their outcome.
Okay, and last one, we're going to take this financial navigators one last. And again, I apologize, we're not going to get to everything, but I will share all of the questions. There are a lot of them that you didn't see, Dr. Wheeler and Dr. Rosenstein, so I'll share those with you afterwards. Do financial navigators stay up to, well, we kind of covered that, the community, national nonprofit charity opportunities. Anything you want to say about that wasn't already said? No. Okay, let's close that out at there, and we want to say lots of thank yous. We want to say thank you to everyone in North Carolina for their hard work and their paying taxes, and a part of that goes to the University Cancer Research Fund, and we are greatly appreciative for that. We want to thank the UNC Lineberger Comprehensive Cancer Center. We want to thank the team, Mary King, Veneranda Obore, John Powell, Anita Woodyard for everything that they do for this and every one of our lectures.